Okay, so let's go back to the 22 weekers. If I asked you, what do you think the cause of death is? So this is sort of, again, a thought question. And under infection, will include, I put necrotizing enterocolitis within the infection category here. So would you think, are most of these babies dying from IVH? Are they dying from respiratory failure? Are they dying from birth trauma or asphyxia or infection? And just think to yourself, what do you think is the main issue of the death of this population? And the main issue is infection. And this is why I brought up those stories of babies being saved because of early diagnosis of subtle signs of infection. We all can diagnose septic shock when we don't have a blood pressure and the baby's amazingly tachycardic and not oxygenating, not ventilating, and poorly perfused. It's too late then. Cytokine release and it's over. So you have to be very hypervigilant. And now the problem is there is a large part of this which is early onset sepsis. And so unfortunately, there's a large portion of these babies that are going to die no matter what we're doing because they come in, mom has severe choreo and the babies are overwhelmingly infected and they often die within the first day or two of life. But again, our approach is a trial of life. If the parents wish us to, we'll do a trial of life. And many of these babies end up surviving. Now, with the trial of life, if a baby here, as you can see, 31% did die of IVH, most of these support was withdrawn. If the baby has a severe grade 4 IVH and the parents want to redirect care to palliative care, we have no issue with that. But a lot of times you just don't know that until that happens. Respiratory failure is very minimal because, again, I feel one of the keys is minimizing value trauma approach. This is a hard one to fix, the perinatal asphyxia, because this would require crash C-sections for fetal distress, and we don't want to be doing that in this population.